Today's keynote speaker, Dr. John Draper, has a unique perspective on what has been learned to date and the possibilities for 988 in relationship to behavioral health crisis response. You know, we have a lot of people here for an 8 a.m. meeting. And I know you did not come out to hear me say what I just said. You came out to hear Dr. Draper, and he's worth waiting for, let me tell you. Dr. Draper has more than 30 years of experience in crisis intervention and suicide prevention work, and is considered an international expert in behavioral health services, including hotline, online chat, and text services, which, if you talk to anyone under the age of 25, is their preferred method of connecting. He began his career as a psychologist, directing a Brooklyn-based mobile crisis team before joining what is now Vibrant Emotional Health to launch New York City's first 24/7 crisis hotline. Dr. Draper led the development and operations of the National Suicide Prevention Lifeline, which he oversaw as its executive director through the launch of 988 in July 2022. In that same year, Dr. Draper joined Behavioral Health Link, Inc., a national leader in crisis services. As president of Research and Development, he continues to apply research, data, and technologies to improve the quality of crisis care systems across the continuum, not just locally, but nationally. It's an honor to welcome Dr. John Draper not only to Columbus, but to the stage.
Thank you. Wow, aren't you all so lucky to have Erica as your outstanding leader here? She's amazing. Amazing. I had the pleasure of spending time with Erica last night and a number of your leaders here in the community that are really dedicated to collaborating to bring 988 to full fruition. And we can't keep our promise of 988 unless we collaborate. And you all have really shown a great deal of collaboration to get you where you are today, which is a very impressive place. When we talk about 988, often we're talking about what it can be in the current state, though, meaning that we often mix up what we think it will be with what it is today, and it's really just in its infancy. We have a long way to go before 988 becomes what it really can be. As you can see, I mean, I don't think after 80 years, hopefully, that it will be so old, it will be better and stronger for sure. But I think we do, this is a reminder that we not only have a long way to go, but we have a lot of challenges in front of us. And I'm going to talk about some of those challenges today. And they range anywhere from capacity issues to getting people to become more aware of what 988 is, and also making sure that we get past this geolocation concerns, which I think are more of a near-term concern, which I'll talk about in a bit. And we've got to build out that crisis care continuum, that care traffic control system that Erica was talking about. Now, when SAMHSA talks about the care traffic control or the entire crisis care continuum that we want to establish, they're very, very ambitious in their aspirations. If you look at their goals here, 2023, by the end of this year, they expect or would like to see that every single one of our states are able to answer crisis calls 90% of the time within the state. Ohio is pretty much there. Most of the states aren't. 2025, they say that's when we think we can get 80% of the folks to have access to mobile crisis services. We are not there in most states and won't probably be there in 2025. In 2027, they say we want to have 80% of people have access to community crisis facilities, crisis receiving facilities. I don't think we're going to get there probably until well into the 2030s. So these are ambitious goals, but we're pretty close, not terribly far with that first goal. Let me tell you where we are with crisis calls around the country. Now, in December 2021, we were way behind in terms of our ability to answer texts and chats. About 1 out of every 4 chats was being answered by the National Suicide Prevention Lifeline. About 1 out of 2 texts was being answered. A little over 80% of the time, we were able to answer the calls. But we need to get up to that 90% if we can. So there was a lot of funds that was put in the lap of crisis centers to make sure that they would be prepared for the 988 launch in last July. And what we saw was a significant change a year later, by December 2022. Nearly 100% of chats and texts are being answered now. Unfortunately, we didn't get to the 90% with crisis calls, about 87% from 81%, but there's a reason for that. And there's also a reason why we were close to 100% with chats and texts. It's about funding. The chats and texts, most of those, the overwhelming number of those are being answered by centers, 25 centers across the country that are directly funded by the federal government through the Lifeline grant to answer chats and texts. So they put enough money in their pockets knowing how many chats and texts they needed to respond to, and so they were properly equipped with the resources to do so. However, with calls, SAMHSA pretty much depends on the states to fund and resource those local crisis centers to answer those calls. So that's quite variable in terms of the willingness and ability of states to fund their local crisis call centers. So take a look at this. This is from December of last year, and this gives you a sense of that variability. So in the navy blue, those are the states that are answering between 90 to 98% of their calls in state. And the deep blue states, 80 to 89%. So you can see that Ohio is in the navy blue, at least they were in December of 2022, and they're still hovering around that 90%. So they're pretty close to that goal. Some of the other states, not so much. Those in orange are states that are answering between 50 to 70% of the calls. And again, this is about resourcing these facilities to be able to respond to the calls for 988. Now here in Ohio, it's a different kind of model. It's very decentralized and localized. There are 19 call centers in Ohio. That's more than any other state in the United States in terms of the number of call centers responding to 988. In fact, there's about 216 crisis centers in the national network, so almost 1 in 10 of the centers in the national network are in Ohio. So this is a different model. It has some upsides and downsides, but certainly an upside of this system right now is it's been very successful in responding to calls very quickly. The average speed of answer, 19 seconds compared to 35 seconds for the rest of the network on average. So that's very impressive. And as I noted, you're answering most of the calls in state. So Ohio right now is meeting the call, meeting the challenge to respond to the needs of people who are dialing 988. How many of our states are funding what we call the full complement of the Crisis Now resources? So to the extent that they're funding not only the call centers, someone to talk to, but also the mobile crisis teams, someone to respond, and the Crisis Now model of crisis receiving facilities, that is a place to go. How many of them are funding all of them? What you see in green are the number of states that are funding all 3 of those components. It looks pretty promising, except that really what that doesn't tell you is how much capacity they have in each one of those states with those facilities that they are funding. Most of them are not 24/7 in terms of their mobile crisis services, and most of the states that are funding crisis receiving facilities have very few of them in very few counties. And we'll see that a little bit is true in Ohio as well. And this is the good news that Erica was talking about earlier that really only came to fruition, again, through a great deal of collaboration and collective vision here. I don't need to go into all of the things that make this a special service for you all. I think you already know that. But this is, I think, going to be a facility that not only a number of people are going to come in to get care, but I also think a number of stakeholders from around the country are going to visit and say, I want to do that too. It's really a terrific model that you're establishing here. And in general, Ohio and Franklin County are on the ball. As you can see here, all of the counties are covered by the someone to talk to notion of Crisis Now. 77%, nearly, this is close to that 80% mark that SAMHSA says we got to have at least 80% of people covered by mobile crisis services, and that's really the case here in Ohio. 77% is very close. Where there's some lacking is the 23-hour observation, the crisis stabilization services. These are crisis receiving facilities, and it's true of most states. Most of them do not have these higher level community-based services that are really going to be crucial to having alternatives to emergency departments. But Franklin County, by 2025, is going to have the whole thing. And that's going to be a very exciting day. Yes, Erica's clapping, and the rest of you should clap as well. It's going to be a big day when that happens. What you see here is it's an interesting resource called the Crisis Resource Need Calculator. I don't know, how many of you all have seen this before? Yeah, it's a resource that was put together by McKinsey Institute in consultation with RI International and the National Association of State Mental Health Program Directors. And what it does is help any community get a sense of what they're going to need to provide the full complement of crisis now care, meaning again, mobile crisis, call center, and crisis receiving facility for all of your residents. And then if you put in a few assumptions, you can say, here's how much it's going to cost, which is really what basically stakeholders and legislators need to know in order to be able to invest in it. So the Crisis Resource Need Calculator, this is for Franklin County. About $144 million is what they say is going to be needed for the entire population of Franklin County. And if you relate that or compare that to the emergency department or inpatient care only as the way to treat crises, that would be a savings of about $157 million. But as Eric and I were talking about last night, it's really not about cost savings. It's what that is going to mean for people in their lives who are getting the care that they need in the right way at the right time. And this also gives you a sense of how many of the mobile crisis teams you might need to be able to service the entire population. 17, the number of receiving chairs and crisis receiving facilities, 72, et cetera. But you can change those assumptions to see what makes sense for your community. It's a nice resource to at least give you a head start in thinking about what it is that you're going to need for funding to keep everything sustained over time. When we think about sustaining funding, what is Ohio doing now to take care of your Crisis Now system? First, starting with the federal funds that SAMHSA provided you all, about $20 million to prepare for 988 for your crisis call centers. That happened for a little over a year, and now the next 2 years, you've got about $46.5 million that have been set aside for your crisis care services, but for sustainable funding over time. So we're not worried each year, are we going to be able to fund this? And as we invest in these really important resources, are we going to be able to sustain them? There's a very, I think, appealing bill, bipartisan bill by Representatives Miller and Pavligo that is being considered that has, I think, two components worth noting here. One is the cell phone carrier fee, which the National Suicide Hotline Improvement Act or Designation Act put in place. It says states can charge cell phone fees for monthly, basically a monthly fee of everyone's cell phone bill that can be used to fund the crisis care continuum. And here in Ohio, there is discussion about up to being 10 cents, which I believe is the placeholder. But if you think about that, that's $1.20 a year that everybody would be investing in for a crisis service that many of them and their loved ones are going to be serviced by. That's a small investment for a huge, huge return. The other thing I think is important about this bill to consider is the 988 administrator is also a part of it. That 988 administrator is going to be helping you all, in the event this passes, to oversee and coordinate those 19 centers that are doing perhaps very different things to make sure that they do something uniform for everybody, so your services are not so radically different based on the county that you're in. So having that uniform set of standards, that uniform oversight, those uniform expectations, while still maintaining some of the individuality and the local politics and needs of those specific communities, without people having to feel like they're being treated differently because they're in a certain county, is really important to have. And having that 988 administrator may allow you all to do that. So again, this bill seems to me to be a very attractive one. What are other states doing? We see about 8 other states that have already enacted this cell phone fee. There's about 29 that have set aside appropriations for 988 services. About 14 states have established a 988 state trust fund. 7 states are studying 988 financing or gaps in crisis system capacity, et cetera. These are, there's a lot of different considerations that states are really dedicated to be looking at right now so they can sustain funding over time. So we don't have to every year wrestle over what are we going to do to keep our crisis services in place. And we're going to need to wrestle with that because we have a lot of challenges ahead. First, starting with capacity issues. We know we're going to get more calls over time. Right now, we don't have this saturated media campaign that is creating an awareness of 988, but over time we will. And this is a projection that was put together by, when I was with the folks at Vibrant, along with the McKinsey Institute. We projected out over 5 years if there was going to be a media campaign that was dedicated to promoting 988 that was saturating both print, online, and broadcast media. In the first year of this campaign, it would be about double of what we're getting now. We have about 5 million contacts last year. This would be, they think, after a year of a saturating media campaign, it would be about 9 million. After 5 years, 5 times that amount we expect could be close to 25 million, and this estimate is 24 million. And we know that there's a lot of people who don't know about 988. All the people in this room know about 988. We are in the minority. 87% of the people who were surveyed, these are adults, by Pew Trust, who did the survey back in May. 87% said they didn't know what 988 was or what its purpose was. And when they were told what it is and what its purpose is, about 7 of 10 of them said, yeah, I'm somewhat or highly likely to contact it. So imagine that there's quite a number of people out there who will contact this service once they learn about what it is. And there's even more of a need not just to make people aware of the service, but educate them about what it is, because there's still a number of people who won't contact the service, who are going to be saying to themselves, no, cops are going to come when I call this. No, I'm going to be hospitalized against my will. No, I'm going to be charged for services that I can't afford. And no, they're going to use my information without my permission. And so we need to educate the public about what these services are, in addition to what they're intended to do. Another big challenge is, which some of you are very familiar with, is the geolocation challenge. And I believe this is a temporary challenge. Geolocation, I'm not sure how many of you know how the Lifeline calls are routed? Okay, they're routed by area code. And we know that, how many people here have cell phones where your cell phone is not in the local area code, your cell phone number? Yeah, so if I'm in crisis, I move here to Columbus, and if I'm in crisis, and my phone its prefix is Brooklyn, and I need help now, I'm gonna call 988, and I'm gonna get answered in New York. And all that money and all those resources and all that dedication and collaboration that you've put together to build these resources that are so specific to this county, I ain't gonna get them. And if I've just taken an overdose and I could be dying, and I can't even tell you where I am because I'm so out of it, they can't find me because they think I'm in New York. They don't know I'm here. And if you give my number to 911, they may not be able to find me either. So this is why we need to address geolocation, and there's two types of geolocation issues that we can look at. One is what we call coarse geolocation. That means just get me to the nearest cell phone tower. If you can just connect the nearest cell phone tower to my call, that will put me to the nearest call center, and then I can avail myself of all the local resources. That's great. Even better is fine geolocation, which will this is what 911 has, which will be able to tell the operators exactly where I am. So we can actually keep our promise when we say we're going to save people's lives. Because in the example that I just gave you, we can't necessarily keep that promise unless we have fine geolocation. I do believe that coarse geolocation is on the way. I've heard from the folks at SAMHSA that they believe sometime, probably within the next few months, that this is going to be very doable. It's probably a longer road to hoe for the fine geolocation. Other two issues worth noting here in the crisis care continuum challenges is first interoperability efficiencies, and also issues related to good care and making sure that we're providing good care in the crisis care continuum. Interoperability challenges, first from the standpoint of 911 to 988. We were just hearing Erica talk about this, which I think is fabulous for Franklin County, and most areas, most PSAPs and 911 centers do not have this, which is a model where you can take non-urgent behavioral health crisis calls and deflect them over to the 988 center. And that's going to be really crucial for us to be able to give people the right care who still don't know about 988, just know about the other three-digit number. And so co-locating some of the staff members from the crisis center in the 988, in the 911 center, is a terrific idea. There's also ways in which you can just triage it at the front end, not as efficiently, but you can do that and then send it over to 988 centers. Also, 911 centers have got to be able to be prepared to provide for 988 centers who've made 911 calls to tell them what happened to those 911 calls. So we know when police respond, did they pick them up? Did they even see them? A lot of times they don't even see them. They bolt. So did they actually see them? And if they did see them, did they transport them to the hospital? And if so, which hospital? So we can send information to that hospital that tells them about why we called 911 in the first place. And all of that really is crucial to maintain the continuum of care of people who are at the highest risk. We also need to be able to determine what's 911's role in generating mobile crisis dispatch. And should they do it directly? In some cases, all cases? And should they do it from the 911 center, or should they transfer it to a separate mobile crisis dispatch center? So likewise, 988, in their relationship to 911, also has some interoperability challenges. As I mentioned, there needs to be that seamless interface. The geolocation, really, that problem underscores, which is, if a person really needs help now, we got to be able to find them, and we got to be able to work with 911 to be able to find them now, or they could die. We also need to be able to obtain the disposition status from 911. I was just saying 911 needs to be able to tell the crisis call centers what happened to the people that they called 911 for, and likewise, 988 centers need to be prepared to contact the 911 centers and get that information so we all know what happened to make sure that this person is taken care of. We also need to have training and collaborations across systems so we know exactly what the police are going to do, and we can explain that to the people that we need to call, saying, hey, the police, when they come, they're going to be doing this. And we also need to be able to train law enforcement officers and 911 dispatchers about how to work with people with serious mental health issues. Finally, with 988, is mobile crisis dispatch, should that be happening directly from the crisis contact center, or should that be an external resource that is just in charge of mobile crisis dispatch that the 988 center contacts and has them take care of? I personally don't love that model as much. I think that's a person telling the story twice. If we have one story being told at the crisis call center, I think that's a much more efficient way of determining dispatch and dispatch levels. So for standards and practices, we do know through years of evaluations of Lifeline call centers what it is, what good care looks like, and what it needs to be in order to be able to reduce risk of suicidality. We don't have such standards and practices or evaluations for mobile crisis teams. In fact, most mobile crisis evaluation studies are decades old. So here are the kinds of things that we do need to establish for mobile crisis services in the coming years. What's the response time? Should it always be 60 minutes? What about for rural areas? Same thing as urban areas? Is that always appropriate to have, if you have scarce resources, to expect all of them to be in 60 minutes? What happens if some of them are better if you schedule them in advance? What's the appropriate time for the person who wants to receive them? And in some cases, if we have various dispatch levels, if a person's at lower risk, can they wait as opposed to people who are at higher risk so we can make sure that they get that immediate response time? There's no data on this at all, so we're just taking a shot in the dark and say, everybody, one size fits all, 60 minutes response time. Assessment standards. We have assessment standards for suicide risk. We do not have assessment standards for risk to others. Should there be a standard or assessment principles for that as well? And for people who are seriously mentally ill or have serious disabilities, to what degree do we have some assessment principles or standards that help us determine what their level of care is? That's important for mobile crisis, but there are no national standards for that. What works for mobile crisis? We don't know. And so we don't have standards for that. We'd also need to know, once we know what works, we need to be able to monitor that care to determine if it's actually happening. We're not monitoring that care either because we don't know what to monitor for. And in terms of training for best practices, because we don't know best practices, we do for crisis call centers, we don't know them for mobile crisis, so we don't know how to train our mobile crisis teams. And what should be the functional capabilities of mobile crisis teams? What should they all be able to do? Should they be able to dispense medication? Should they all have peer support? These are all things that there are no national standards for. There's suggested guidelines, and some of those guidelines have a lot of holes in them. But again, we do not have national standards. We should have standards for keeping our staff safe in the community, who are in the community helping people. We have no standards for that. And we should have uniform dispatch levels, going from lowest risk to highest risk, that helps us determine what mobile crisis teams should be dispatched, under what circumstances, and when should the police arrive. But we do not have national standards for that either. Lastly, I want to note what I think is going to transform in our behavioral health care system as a result of 988. For years, crisis services, suicide prevention services have been on the periphery of behavioral health care systems. They've been either in crisis call centers or in inpatient facilities or emergency departments. If we bring together, as we will with 988, suicide prevention services and crisis services, and we integrate that into the behavioral health care system, a lot of the things that we do and we've learned in crisis care systems and suicide prevention work will become part of the continuum of care. I'm very excited about that we will become one. We will learn a lot from behavioral health care system, and they're going to learn a lot from the crisis care system. One thing that they're also going to learn is how to operate differently. They're going to need to operate differently in behavioral health care systems because people are going to enter that front door of 988 with different expectations. They're going to think, I could get care at home. And often, they should be getting care at home. It shouldn't always be happening in offices. Yes, in some circumstances, it should only happen in offices. In other circumstances, it absolutely should be happening in the home. It's rarely happening in the home. There are very few behavioral health care services occurring in the home. And also, when and how to get that care, 24/7, I ought to be able to occasionally zoom in. I should have that telehealth option. I should be able to chat or text with my practitioner. I should be able to connect with them in different ways. Right now, you just got to show up at the office at a certain time, and that's when we're going to contact each other. So these expectations will change the way in which I believe a lot of our behavioral health care systems operate. We're also going to be collecting a whole lot more data about what people need in the systems and what they're not getting in the systems. So we're going to learn essentially about new services that are not there, that we have not even thought of yet. So I imagine in 10, 15 years, we're going to be talking about very different services beyond the three that we just talked about. We talk about call centers, we talk about mobile crisis teams and crisis receiving facilities. That's just the tip of the iceberg, I think, over time. We're going to have a lot more of our workforce that's going to be interested in crisis care. Just like when 911 came along, a lot more people learned about emergency medicine. There's going to be a number of folks who are really turned on by this notion of working with people in crisis. I never received any education, any guidance. I knew nothing about crisis care when I was in graduate school. Future graduate schools will be talking about 988 and crisis care in a way that we didn't even know about 20 years ago. And I think overall we will see a reduction in stigma in mental illness and mental health. I imagine that 25 years from now, I will have grandkids, maybe even great-grandkids saying, really? Is it true that cops used to come to your door if you were thinking about suicide? And again, I think that, as my daughter said, when I asked her about 988, when she was 18, what she thought about this three-digit number, she said, Dad, I think it's going to do more than anything that we could ever do to eliminate discrimination and stigma with mental illness. And I said, why is that? And she said, because we know with the three-digit number for medical emergencies that those are real, but people just don't know that psychological emergencies are real. So they're going to learn that they're real and they require a really different response. People who really care. And that's all the folks in this room. Thank you for joining me today.